Hello, this is Tracheostomy Chapter 2. So let me share my screen and let's get rolling. So when it comes to tracheostomies, there is some nursing management that we are responsible for, of course, that's why we're talking about it. So part of our job is to explain the purpose of the procedure, either to the client or if they're not with it enough to perhaps to some family members. And then we also help prep. So we're either preparing the patient for surgery in the operating room or for bedside insertion. If the surgical OR nurses take care of the surgery prep, the bedside insertions usually happen on an intensive care unit. So the intensive care unit nurse would be responsible for gathering all the necessary supplies and making sure all the kits. Both nurses are responsible for gathering the supplies, making sure that the kits are in place, because when you're working with an airway, you want to have every possible thing that you could possibly need at the bedside and then make your hole. So for bedside insertion, we also want to make sure that the respiratory therapy is available. There is emergency equipment available, like a bag valve mask. The nurse will be recording vital signs, SpO2 readings. They need to make sure that the IV is patent. Please make sure the IV is patent before the insertion. We'll be looking to make sure that there's bedside suction because we're making a hole. The hole is going to cause some stuff to come out. We're going to have the patient lying flat, supine on their back, and then we will be administering analgesia and or sedation per protocols by the doc. If the client is in the OR, then the nurse anesthetist that is there does a lot of this stuff. So the nurse anesthetist or the anesthesiologist, depending upon who's doing that end of things with the OR. Post-procedural care, regardless if you have it done in the OR or in the bedside, post-procedural care is the same. We need to make sure that that obturator is out. That hard piece of metal that makes that tube less flexible and more easy to insert is not patent. It needs to come out so that the patient can actually use their airway. We'll make sure that the balloon is inflated. There's actually a little, if you remember in the picture, there's a little pillow outside of the body that lets us know if the balloon on the inside of the body is inflated. And there will be auscultation for air entry. There will be end-tidal CO2 capnography. And then we'll also pass a suction catheter through there, but the gold standard for placement is a chest X-ray. The tracheostomy should be sutured in place and secured, and the nurse will be monitoring vital signs, SpO2, mechanical ventilator settings. The first at least 12, if not 24 hours for a tracheostomy, this is an ICU level patient. We just mucked with their airway. So they need to be in a smaller assignment with closer monitoring to make sure that that airway stays open and that that client can actually start the other conjugate therapy or the subsequent therapies that they need to do. So that's why this patient, because we've literally just mucked with their airway, they're on the ICU for just 12 to 24 hours. In addition to these, then we will also be monitoring the patient for complications such as bleeding, airway obstruction, and infection. So bleeding is an immediate thing. Airway obstruction is an immediate thing. Infection can take 24 to 48 to 96 hours to present. So we will keep an eye on that client for quite a while. And infection will actually be part of our patient education of that client as well. But bleeding, there's a lot of bleeding that happens almost right away because we just made a hole, right? And there can be airway obstruction. What will happen is because we just made a hole, there is a great deal of mucus that the body will produce, and that mucus can plug up your nice new airway. We'll be assessing site and patency at least every shift, usually much more frequently just post-operatively on medical surgical units. That patency will be a little bit less often. Monitoring the cuff pressure, we want it between 20 to 25 centimeters of water. We want minimal occlusion volume. We're going to be suctioning per request as needed. That's going to be quite a bit because we just made this new hole in the airway. The body is going to try and kick this thing out. The way it kicks things out of the airway is by attacking it with white blood cells, secretions, and inflammation. So there's going to be lots of stuff happening in this region. We'll want to make sure that they're on humidified air because it thins the secretion and reduces the mucus plugs. Mucus can easily plug up these brand new tubes. So the humidified air keeps the secretions thinner and allows them to be suctioned that much easily. And we'll be performing tracheostomy care per our agency policy. Here's a picture of a gentleman who has a tracheostomy. So I wanted to make sure that we went through this picture because every tracheostomy should be outfitted with, most likely, a closed system suction catheter, which you can use to, especially in the first, like that first period of time where the body is really fighting having this new thing. We're gonna be doing a lot of suctioning. The inline suctioning is a lot easier. It can be done a lot faster. You don't have to assemble as much equipment. Remember last semester when you were learning how to do nasal oral suctioning, this is a little bit faster. Like I said, you don't have to assemble as much. And then everything's just right at the bedside. So I'm going to be moving on to this next slide, and then I'm going to end this chapter. So primarily what we're doing when we're doing this first 12 to 24 acute inpatient stay with the tracheostomy is we have one job, and that is to prevent dislodgement. When it comes to a new tracheostomy, we have one job because they've got this new airway. We need to prevent dislodgement. We need to make sure that when we're turning and repositioning them, that we're not accidentally dislodging it, because remember, it's going to be hooked up just like we saw in this last picture. It's hooked up to all of this respiratory equipment. These blue lines lead to a ventilation or a ventilator. So we need to make sure that when we're turning, we're not actually, like if we were going to be turning him towards the person who's suctioning, we need to make sure that there's plenty of slack in this line and it's not going to pull out all of that airway that we just worked so hard to establish. There needs to be a replacement tube of equal or smaller size at the bedside. And we're going to leave those trach ties, the trach tapes, for at least 24 hours after placement. If there needs to be a tube change in the first 7 days after placement, the healthcare provider is going to be doing that, whether it's them or maybe one of their assistants, like a nurse practitioner or a PA or that MD, somebody who has a little bit more education than even a bachelor's per nurse is going to be doing that first tube change out. If there's an accidental dislodgement, that my facility, because this is an airway problem, we called a code. So we would treat dislodgement of a fresh trach as a code situation. So institution policies and procedures, knowing your scope of practice, and we're going to be assessing and for respiratory distress, but that code will get people there quite quickly. So to help you keep that airway patent. So I'm going to stop sharing right now, and I'm going to end chapter 2, and then I will see you for chapter 3.